Hello everybody, it's David McIntosh, the ENT doctor. It's been a little while since I've done a video, and these videos generally seem to be well received. So I wanted to do one today to try and explain something to you all as to why it is so important that we get children assessed not only by ENT doctors but also by dentists when it comes to breathing problems. And the big breathing problem that is important to highlight is related to the top of the jaw. So in medical terminology, we call the top jaw the maxilla. And when we look inside the mouth, what we're looking at is the palate. So the palate is the roof of the mouth, and there's two parts. There's the hard palate and the soft palate. The hard palate is the bone bit, so that's the maxilla bit. And that's what we're going to focus on for my brief chat today. When it comes to maxilla, let's just do a little bit of a visual. So let's say this, going from my thumbs, is the top jaw, okay? And the nose, which is now the triangle that I'm forming, sits on top of that jaw, okay? If, for whatever reason, someone has a narrow maxilla, so the jaw is in tight, it tends to be lifted up at the same time, okay? So they have what we call a high arched palate because it forms an arch type shape. So we've got the nose on top. Now, if you use this as a window and you're looking at my face, looking through the window, this is the inside of the nose. Look what happens when the jaw is narrow and high arched. See how there's very little space all of a sudden? You can see me, and now I'm hiding behind my hands, okay? If you look through the window, all you can see is my nose. Okay, so that's what happens in kids that have a narrow maxilla, is that the upper jaw comes in close and makes the space of the nose less. And the reason that's important is that with reduced space, it's very easy for that nose to get blocked. It makes it's an easier situation or scenario where the nose can become blocked. So within the nose, we have some swellings that sit on the side, okay? So I'm going to turn my hands like this now. So instead of like this, I'm going to bring these swellings into the equation. Now, new word for the day, these swellings are called turbinates, okay? And the problem can be, if the nose is in, we've got very little room, okay? So we can look inside people's noses, the narrow jaw, small nasal space, the turbinates are blocking that space. Now, the important thing that dentists can do is that they can make the jaw wider. So they can what's called expand the jaw, or maxillary expansion. So why would we bother with an ENT? Well, the reason is that maxillary expansion isn't for everybody. And one of the important things for maxillary expansion to work is that you need to be able to breathe through the nose. Because if you cannot breathe through your nose to start with, you tend to have your mouth open, okay? And if you have a feel on yourself, that opening of the mouth holds the nose and the jaws in, okay? So it actually stops it from springing out. So the dentist is trying to push it out and your mouth breathing pushing it in. So what we do as ENTs is we work out a way of getting the nose clear. So if the turbinates are too big because of allergies, those sorts of things, there's the option of nasal sprays. If they're not responsive to nasal sprays or it's not thought to be the most appropriate option, surgery is another option where we can make the turbinates smaller. So that's called a turbinate reduction. And there are different varieties of turbinate surgery. So there's what's called a submucous resection, which is where we take out some soft tissue and bone. There's a machine called a coblation or radiofrequency device, which can melt the tissue away. And then we have a thing called cautery, which is where we burn. And each have their pluses or minuses. The downside, particularly with cautery, is that it's really, for a lot of kids, it's a temporary measure. It might buy us 6 to 12 months, and if we start to see relapses, we start to see them pretty early. When the kids are really little, we really don't have much choice. Like, we can't physically get into there and do much else. So it might just be a time-buying exercise. And then we sort of warn people that you'll be back, potentially in a year or so, and we need to do some more. That's all incidental to the fact that basically we've got narrow nose, turbinates in the way. At least we can get the turbinates out the way. So we can go from this to that. That's a step in the right direction. If behind the nose the adenoids are big, we can get those out the way, and that way we've got someone that's actually got some air channels that actually can take some air through, okay? And then the dentist can take the jaw out and open up the space. The other reason that's important is because we've got to work with downstairs as well, all right? So downstairs is inside the throat. So we've got our top jaw, nose, we're going to spin it round now. So this is still the top jaw, but this is the side walls of the throat, okay? And if they've got a narrow maxilla, again, look at what happens to the space between the side walls of the throat. Okay, we have less space again. And the reason that's a problem, if we have less space, is that it makes it easier for things like the tonsils to block that space up. So the tonsils don't necessarily need to be that big to be causing a problem if the space is compromised. So the important thing as to how this all works as a team is that the ENTs need to identify what are the problems that are going on, what can we do, and what is the priority to get the airway opened up. And if it's a high priority, then we need to get it opened up really quick. We can't wait for the dental jaw changes to take place. And apart from that, the things that are contributing to potentially the jaw coming in need to be removed out the way. So we need to get the structural things right first. And then we need to work on the function, because the other thing that we think, and there's some research that backs this up, is that one of the reasons that the top jaw ends up like this is that the tongue couldn't lift up properly to push it out. So the tongue comes up and expands things outwards. And we've focused on tongue tie as being sort of, something that we thought was really important, and it probably is, but some of the more contemporary thinking is that a lot of it actually has got to do with breathing problems in terms of things that we can do something about. People talk about genetics. We can't change our genetics. So we've got to work on what are the environmental factors that we can deal with. And one of the really important environmental things is being able to breathe properly, in particular breathing through the nose. So the things that make children a high priority in terms of getting their breathing sorted are children that are mouth breathing, that are snoring, in particular if they've got sleep apnea, anything that relates to an obstructed breathing pattern. And especially if they've got other symptoms or consequences. So that can be things such as waking up tired because they're not sleeping properly, having trouble during the day, again, because they haven't slept properly. Signs that their brain is not calm and relaxed. So if they're sleepwalking or sleep talking, there's some overactivity of brain function there that shouldn't be manifesting. If the brain's in a really agitated state, they might be having things called night terrors. And then the other thing, which is really common that the dentists are picking up, is teeth grinding. And we'd put teeth grinding down to stress and so forth, but it's really unusual that little kids are walking around stressed about the sort of things that adults have to deal with. There's no fun growing up. And that's been a mistake. The stress is a physiological stress, and then the research shows this as well. So what happens is that there's a pattern that we can observe. So the first thing that happens is they have disruption to their breathing, which results in the oxygen level dropping down to some degree. And it doesn't have to be by a lot, it can just be by a little bit. And this oxygen drop in some kids triggers a stress response, and that stress response results in a surge of adrenaline, which is like your body stress fight or flight hormone. And the heart rate and the blood pressure go up because basically the brain is detected it's not getting enough oxygen, and one of the ways that the brain can deal with that is to get the heart to pump more blood through. So the heart rate goes up, the blood pressure goes up, pump more blood to the brain. What then happens or follows on from that is that within and near the heart, there's little receptors in the blood vessels that go, whoa, blood pressure's too high, need to bring it down. So it sends a message to the brain that says, need to calm down here. And part of that message filters through a nerve, which also connects to the muscles around the jaw that open and close the jaw. And as a result of that nerve is stimulated. And if it gets stimulated through the muscle part, then the muscles start to move and they start to grind their teeth. So what we found is that in sort of 80 to 90% of children that are grinding their teeth at night, they've got a breathing problem. You might see the dentist, but then the dentist is going to bounce them to an ENT. And that ENT needs to understand the connection. They need to be able to take it seriously, because basically we need to get these children breathing properly. And again, there's different ways of doing that. But the important thing is that we get them breathing properly in a hurry. Teeth grinding has all sorts of terrible consequences to the state of their teeth. The pressure can up into the jaw, get jaw pain, headaches, really not very good at all. And by the way, it's the same in adults too. Yes, obviously, people get stressed, but we've got to make sure they're not getting stressed because they can't breathe properly. So this was going to be a short video. I blew that budget already, but I think this is succinct enough. So I just want you to understand the importance of dentistry, the importance of the top jaw, and why that with dental point of view, they say, look, we've got to get the jaw out and get them breathing properly, and we want the ENT to go first. The reason is that even if they push the jaw out, if there's still some blockage within that nose, even when it's out, they're going to continue to mouth breathe. And that is then going to put the pressure so this bounces back again. So from my point of view, in terms of how I look at these things, I think if any child is going to be having any sort of jaw orthodontic type treatments and there's any suggestion of a breathing problem, then that child needs to see an ENT before the orthodontics even starts. And that's very controversial for some people and they find it difficult to accept. And mostly they find it difficult to accept because it's not what they were taught. But we all know that there are lots of things that we were taught that as time goes by is improved upon and modified, and we need to adjust to new knowledge. So we've got the knowledge out there showing that for children having jaw orthodontic treatments, if they have a breathing problem and if that's not addressed early on at the beginning prior to treatment, or at least in the first sort of 2 to 3 months of starting orthodontic treatment, their outcomes don't seem to be as good on a population level as what it would have been for those that had their breathing sorted first. So the research also shows that, and it's not no one's fault, is that people doing orthodontics aren't necessarily fully trained in every aspect of checking for breathing problems, but it's become part of the guidelines. So in the United States, it's part of the American Orthodontic Association guidelines. It's also similar in Britain, where dentists and orthodontic treatments are expected to be screening for airway problems. And the orthodontic and dental people need to take these airway problems seriously. They need to understand, as much as we understand at the moment, just how important it is to be able to breathe properly. It's not a challenging concept, hopefully for most. So I just want to share this knowledge. It's a gloss over of things. It's a very deep and complicated topic, but if I can just give you a few visuals just to try and give you something to work with that kind of makes sense, then at least you'll have a better understanding and insight into why we do what we do and why dentists and orthodontists do what they do, and for those that don't, why we would encourage them to reconsider how they do things and just look at it in a different light. Because I'm very lucky. I get a lot of support from people that do orthodontics, and I have people that have been doing orthodontics longer than I've been an ENT, and they've seen what their cases were like back when they used to just sort out the orthodontics and so forth. And then they started, finding these children and sending them to me. And through the evolution of time, that there's some people that now actually refuse to start any orthodontic treatment until the breathing is sorted. Because they've seen such a difference in their own mind in terms of how the children are in themselves and how they progress with treatment, that really they don't want to go back to the old way. So I'm very privileged and grateful for the people that recognize that and support that. So that's enough for now. That's a good juicy bit of information for you all to digest. And I look forward to continuing my efforts to educate and share my perspectives. All my things are always evidence-based. If there's no evidence, then I will highlight where there's speculation involved. I won't get carried away with the next big thing in terms of what's out there. So I always like to keep grounded with the evidence and the research, and I use that to allow it to change my viewpoints. There's a lot of people that disagree with things that have been said, and that's okay. It's important that they disagree reflecting on the evidence, not reflecting on their education. Because what I know now, in the mainstay, I was not taught as part of ENT. And I'm very lucky to really have the knowledge that I've got because I took on that multidisciplinary approach of including other elements from everybody, so I can understand how this all comes together. So again, I'll leave you to it. Have a good day. Bye.